And hi, Rachel. I'm answering your question. Actually, I just answered it. I just provided a video and then at the end of it realized I didn't have the microphone on. So now I'm going to repeat the answer with sound. Rachel, you asked, how do I visualize the clinical management of individuals who have significant damage to their frontotemporal regions, yet it is not of a degenerative nature, so a brain tumor or a traumatic brain injury. You say here that these individuals present with all the symptoms consistent of FTD, yet doctors hesitate to call it dementia and instead call it things like dysexecutive syndrome or dysregulation of the frontal lobe. And quite rightly they do. So I also would very much hesitate to call a brain injury a dementia. However, and this I guess is the tricky part, dementia itself is a type of brain injury, but brain injury is not necessarily a type of dementia. And the reason for that is a brain injury or a brain tumour can cause focal damage and symptoms that are similar to FTD, depending upon the area of the brain region that is damaged. So part of the cerebral cortex, the lateral lobes, frontal lobes, temporal lobes will perhaps present with symptoms like FTD. So this behavioural disinhibition, language deficits, executive function problems, so planning and judgment and insight, you'll see problems there. But I guess the qualifying difference is that given the neuroplasticity of the brain, with a brain injury, we can see reparation. We can see new neural connections form after the injury. And this, you'll often see this in the first 6 months and up to 2 years. Usually by about 2 years, if there hasn't been an improvement in function, there is unlikely to be one. But we do see repair. And that's why you'll work with specialists to try and improve that behavioural and cognitive function after a brain injury. With dementia, however, and I'm going to generalise because there are some types of dementia that are not necessarily neurodegenerative or progressive in nature, that they can plateau. But I won't go off into that. I'll generalise. Most dementias are of a neurodegenerative and progressive nature, so we're not going to see neural repair. To the opposite, to the contrary, you're going to see continual degeneration. However, because both a brain injury and dementia can impair function of the brain and intercept those neural pathways, you can see similar symptoms. So you asked about how that's managed. Well, the symptoms are managed similarly. The treatment, at least the behavioural and psychological interventions we would use, would be similar. And treating the symptoms and not the cause. So certainly with dementia, we know medications can perhaps manage some of the behavioural presentations and can slow some of those symptoms down, but it's not going to fix the dementia. So we treat the symptoms of brain injury and the symptoms of dementia in a similar way through behavioural management strategies. But I guess the point of my answer is that doctors would hesitate to call brain injury and brain tumour a dementia because they're not necessarily a dementia. We do know that multiple concussions and even a single event head injury can lead to a dementia, but in and of itself, it is not a dementia. However, a dementia, because it injures the brain structure, is a type of brain injury. I hope that answers your question, and I hope the sound has worked this time. If I haven't answered sufficiently, please let me know, and I'm happy to qualify my answer. Thank you for the question, Rachel. Bye-bye.